Today, I'll be reviewing conditions limiting mobility. We're going to start with ALS or amyotrophic lateral sclerosis. It's also known as Lou Gehrig's disease. And this is a rare neurological disease that affects motor neurons, those nerve cells in the brain and spinal cord that control voluntary muscle movement. ALS is a nervous system disease that weakens muscles and impacts physical function. So what we see in ALS is that nerve cells break down, and this causes reduced functionalities in the muscles that they supply. What are possible causes of ALS? It could be as a result of genetic or familial history, as a result of chronic viral or slow viral infection, maybe autoimmune disease or environmental factors like toxins or metabolites. And when we assess our clients with ALS, we're going to notice tongue fatigue, and even atrophy with fasciculations. So there will be this brief muscle twitching. So that atrophy and fasciculation of the tongue actually suggests the presence of lower neuron disease. There would also be nasal quality to their speech. You would notice dysarthria. So what's dysarthria again? It's actually a motor speech disorder that makes it difficult to form and pronounce words. So there's going to be dysarthria. You would see dysphagia, aspiration. They will have these swallowing difficulties. You would also notice progressive muscular weakness. There will be muscular wasting. There will be atrophy and spasticity. And this usually begins in the upper extremities. The distal portions are affected first. And again, we're going to see those fasciculations. So you always see fasciculations when innervations from the peripheral nervous systems to the muscles are not working correctly, and the muscles are being triggered involuntarily. So it's going to be causing it to twitch, like we mentioned. There would also be emotional liability. We would also see cognitive dysfunction. Emotional liability refers to a rapid, often exaggerated changes in the patient's mood. So we notice strong emotions or feelings occurring. They can have this uncontrollable laughing or crying, or they will have this heightened irritability. So that's what we refer to as emotional lability. We would also see respiratory insufficiency. So you need to look out for this because this is the usual cause of death in clients with ALS. And there will be no alteration in autonomic, sensory, or mental function. What's our plan for this client? We want to apply principles of care of clients with progressive terminal disease. We want to treat self-care deficits symptomatically. We want to maintain adequate nutrition. We need to carry out physical therapy, speech therapy. Remember, the aim of physical therapy is to relieve pain. So it's going to help them move better or strengthen weakened muscles. We'll need to provide adaptive home equipment. So this would be any tool or device that is used to help with any task that is associated with daily living. We'd also need to provide psychosocial support to these clients. With joint disorders, this would be any disease of the joints, such as osteoarthritis, rheumatoid arthritis, or even gout. Let's look at risk factors for any of these joint disorders. With osteoarthritis, increased age is a risk factor for developing osteoarthritis, obesity, even trauma to joints due to repetitive use. For example, a farmer or somebody who is into sports, so you can have osteoarthritis from sports injury, or from a construction worker or someone who even installs carpets. So that trauma to the joint due to repetitive use also places the client at risk for osteoarthritis. With rheumatoid arthritis, you would usually see a positive family history, which places the client at risk. And with gout, the most common risk factor would be diuretics. So again, remember, diuretics can increase the risk of developing gout, where you have this buildup of uric acid crystals in the joints. And this may happen because these diuretics increase urination, so it reduces the amount of fluid in the body and then causes that buildup of uric acid crystals in the joints. Other family risk factors would be obesity and also a family history. One major diagnostic test we will need to carry out would be arthrosynthesis. So this would be needle puncture of a joint space to remove accumulated fluid. So when we're carrying out this procedure, it's essential to maintain strict asepsis to avoid infection, and after which usually an elastic bandage will be wrapped around the joint, and the joint will be rested for 24 hours. This is to prevent hemorrhage in your client. We would also need to carry out arthroscopy, meaning to visualize. So this would be direct visualization of a joint by use of an arthroscope. Normally, a local anesthesia is given. You also want to teach the client to carry out breathing exercises. This will help to reduce discomfort, and a bulky pressure dressing is applied after the test. So let's look at the types of the joint disease, what we see when we assess our diagnosis, our diagnostic test. So with rheumatoid arthritis or juvenile rheumatoid arthritis, when you assess your client, you're going to see joint pain, swelling, and limitation of movement. We'll see contracture deformity. So that will be when you have stiffness or constriction in the connective tissues of the body. So that's what we refer to as contracture deformity. We'll see nodules over bony prominences. We'll see ulnar deviation, high fever, and rheumatoid rash, particularly seen in juvenile rheumatoid arthritis. And there would also be this salmon pink macular rash that is seen on the chest, on the thighs, and upper arms. In terms of our diagnosis, we're going to see pannus formation. Pannus is an extra type of growth in the joints that can cause pain, swelling, and damage to the bones, cartilage, and other tissues. We're going to see pannus formation. We're also going to see bony ankylosis. This is a medical condition in which a joint becomes fused with the bone tissue, and it can cause severe pain and even limited mobility in the affected area. Well, this condition is going to be progressive, and there's going to be periods of remissions and exacerbations. In terms of our diagnostic tests for this condition, the rheumatoid factor is one, but again, it may be negative. We need to carry out C-reactive protein, ESR, ANA, aspiration of synovial fluid, and also we can carry out X-rays. In terms of our nursing considerations for rheumatoid arthritis or juvenile rheumatoid arthritis, we need to manage the client's pain. We need to rest the joints, encourage activity and exercise. If the client is obese, we want to ensure weight control. We can use heat, maybe warm top baths or moist compress or paraffin dips. This will be helpful. We'll need to splint the joints. We'll need to give analgesics, anti-inflammatory drugs. We'll also need to give disease-modifying anti-rheumatic drugs, immunosuppressive, and anti-tumor necrosis drugs. With osteoarthritis, again, in terms of our assessment, we're going to see joint pain and swelling. We'll see limitation of movement. We'll also see contracture deformities. Again, we said contracture deformity would be the result of stiffness in the connective tissues of the body. We would also see joint stiffness after rest. So even after rest, they still have this joint stiffness. And we'll see Heberden's and Bouchard's nodes of the fingers. It's almost the same thing with the gout. There's still the joint pain and swelling and limitations of movement. There's a contracture deformity. But with gout, we'll see these tophies. So again, what are these Heberden's and Bouchard's nodes? So this would be our Heberden's node. So this will be bony bumps on the finger joints closest to the fingernails. These are called the Heberden's nodes. So if you see those bony bumps on the finger joint closest to the fingernails, they are referred to as Heberden nodes. If we have those bony bumps on the middle or the middle joint of the finger, these are called Bouchard's nodes. Again, you want to take note of those. Okay, so we'll go back to our diagnosis with our osteoarthritis. We'll notice spore formation. We'll notice closure of joint spaces. Again, this is degenerative. There are no remissions. We can carry out X-ray to show those narrowing of the joint spaces in terms of our management, pain management, rest, activity, exercise. We want to gain weight control. Then we want to give medications like our analgesics and our anti-inflammatory drugs, and we'll need to apply heat. With gout, again, part of our diagnosis, we're going to see disturbed purine metabolism. There will be elevated uric acid in the blood. We'll notice these deposits of urates in the joints. That's what we refer to as tophi formation. So there will be deposits of urates in the joints. And again, we would also see exacerbations. With our diagnostic tests, we'll need to carry out X-rays, carry out blood tests, especially our uric acid level. We can also carry out synovial aspiration. And in terms of our nursing consideration, pain management will be key. Also, diet is also key because you want to educate the client to avoid meats rich in proteins like your organ meat, your sardines, and even fish. We need to tell them to avoid alcohol. We need to tell them to avoid dehydration and ketoacidosis. For pain management, we could give our aspirin, our analgesics, and we would also give medications for gout. Let's quickly look at bursitis. Bursitis would be painful swelling in a small fluid-filled sac. So this is actually called our bursas. So again, with bursitis, you're going to see painful swelling in a small fluid-filled sac. So these fluid-filled sacs are usually between muscles and tendons and bones. Particularly, it affects the shoulders, the bursas in the shoulders, the elbow, and even the knee. In terms of our assessments, like we said, there's going to be pain due to that inflammation. And again, the client would have decreased mobility. Our plan for a client with bursitis would be to rest the area. We want to immobilize the affected joints with maybe pillows, splints, or slings. We want to administer pain medications, give your muscle relaxants like our diazepam. We want to give steroids. We want to apply heat or cold packs. This is going to help to decrease the swelling. We want to promote exercise, especially those range of motion exercises. We want to assist in performance of activities of daily living by modifying activities relative to their limitations. And we want to assist with cortisone injections. We want to assist with draining of the bursa that is inflamed. With developmental dysplasia of the hip, this is a condition where the ball and socket joint of the hip does not properly form in babies and young children. So what you see is that the acetabulum is unable to hold the head of the femur. So again, we said it's a condition where the ball and socket joint of the hip does not form properly in babies and young adults. So what are predisposing factors to DDH? One of them will be intrauterine position or breech position. It's more common with female gender. It's more common with hormonal imbalance, especially with estrogen. And again, the cultural and environmental influences also play a role with DDH. With our assessment, what are we going to see? So we're going to see asymmetric skin folds on the thighs and buttocks. So you can see we have more folds on this limb than what we have on the other limb. We would also see limited abduction of the hip in this client. So abduction of the hip would be limited, so you can see. And then there will be leg length discrepancy. So you can see one leg is longer than the other. So just to break it down again, what are we going to see with assessment? We're going to see uneven gluteal folds and thigh creases. Again, it will be deeper on the affected side. We already said there will be limited abduction of the hip, and again, that will be with pain. We said there will be unequal knee height with thigh flexion. We would also notice shortened limb on the affected side, especially in older infants and children. You would also see Otolani sign. This is seen in infants less than 4 weeks old. Again, what is the Otolani sign? So again, with Otolani sign, we want to place the infant on their back with the leg flexed, and you would hear a click sound when the affected hip is moved to abduction. So you want to place the infant on their back, and then you want to try to place the affected hip or move the affected hip to abduction, and you will hear this click sound. That's the otolanic sign that confirms developmental dysplasia of the hip. As part of our assessment, we'll also notice delays in walking. There will be a limp. We'll see lordosis. What's lordosis again? That curving inward of the lower back. We'll also notice waddling gait with older children. So what's our plan for this client? For the newborn to 6 months of age, intervention is going to vary with the age and the extent of the DDH. We could reduce by manipulation. So you're going to manipulate the child's joint, maybe using a cast or a brace. That will be a close reduction, or maybe carrying out an operation to put the thigh bone in the socket. That will be an open reduction. And then we're going to splint with the proximal femur centered in the acetabulum in position of flexion. So after reduction, we're going to splint. We can also use a Pavlik harness. With a Pavlik harness, this is worn full time for 3 to 6 months until the hip is stable for infants, again, less than 3 months of age. So again, we're going to wear this for 3 to 6 months until the hip is stable. So this is what a Pavlik harness looks like. So you have a soft brace that helps to hold the baby's leg in a position that allows their hip joint to be aligned and stable so that it develops correctly. It's a dynamic brace, meaning it's not rigid. It allows the baby to move their legs. So you have an abduction strap, you have a chest strap, there's a shoulder strap, we have the flexion strap, and we have the booty strap. For these clients, we'll need to encourage normal growth and development by allowing the child to perform appropriate activities. We want to teach the parents to reapply the harness. We also want to teach them the rationale for maintaining abduction in their child. So they need to know and be carried along. We would also want to discuss modifications in bathing and dressing and diapering their infants with the parents. Again, remember, since the harness is not to be removed, we want to recommend sponge bathing in this client. You want to put the undershirts under the chest straps and knee socks under the foot and leg pieces. This is going to help to prevent skin irritation. You want to check the skin areas 2 to 3 times a day. We want to gently massage the skin under the straps daily to stimulate circulation. We want to avoid use of lotions and powders. We want to place diapers under straps. We want to pad shoulder straps as needed. And you want to tell the parents to touch and hold their child to express affection and reinforce security. You want to tell the parents to move the child from one room to another, just for that environmental change. For a client 16 to 18 months, we can carry out gradual reduction by traction. We can use a bilateral Byron's traction. We can also carry out casts for immobilization. With the older child, we'll use traction preliminary, and then we can carry out open reduction, and we can use a hip speaker cast to immobilize the limb. So this is what your hip speaker cast would look like. So again, the goal is to have the hip joint alignment reestablished and to have the child's growth and developmental needs met. With herniated intervertebral discs, so a herniated disc or a slipped disc or a ruptured or bulged disc is a fragment of a disc nucleus that is displaced out of the annulus or the outer layer into the spinal canal through a tear or rupture in the annulus. So again, this is the nucleus, this is our annulus, this is a normal disc, but you can see that the nucleus has been displaced out of the annulus or the outer layer into the spinal canal. And again, due to this displacement, what's going to happen? The disc is going to be present on the spinal nerves, and it's going to be producing pain, and this pain may be severe. So again, when we assess these patients, they're going to complain of low back pain. They tell you like it's like a knife is stabbing them. There's this knife-like pain that you see with herniated intervertebral discs. They will have poor posture, even lack of muscle tone. We'll need to carry out diagnostic procedures like our computerized tomography or CT or our magnetic resonance imaging. We'd also need to carry out myelography. With myelography, you want to encourage fluids. You want to keep the head of the bed elevated 30 degrees. This is going to help to reduce the risk of seizures in your clients. Again, you want to remember that for the Nclex, with myelography, remember with myelography is a radiographic examination that uses a contrast medium to detect pathology of the spinal cord. So because of that contrast medium, we'll need to encourage fluids in our patient. And again, we said we'll need to keep the head of the bed elevated 30 degrees to reduce risks of seizures. We can also carry out a discogram. As part of our management, we'll need to carry out surgical procedures like our laminectomy. Laminectomy would be an excision of a portion of the lamina to expose the affected discs for removal. So that would be a laminectomy. So ectomy means cutting out or excision. We can also carry out laminectomy with fusion. Again, this would involve several discs, and the operation uses bone grafts to strengthen the weakened vertebral column. We can also carry out minimally invasive surgery or a microdiscectomy. We can also manage this patient with interbody cage fusion. Interbody cage fusion uses carbon fiber cylinders to fuse two vertebrae together. So the diseased disc is removed and two interbody cages are placed in the opening where that disc has been removed. And then the cage is filled with bone grafts. That's one other way to manage our clients. In the preoperative period, how do we manage these clients with herniated intervertebral discs? We want to apply moist heat. We want to put the client in Fowler's position with moderate hip and knee flexion. We want to use a firm mattress or a bedboard or floor for that back support. We want to carry out isometric exercises for abdominal muscles. daily exercise programs. You want to assist with exercises initiated in physical therapy. Remember, physical therapy helps with pain management. We want to give medications like our muscle relaxants, our NSAIDs, our analgesics. We might use traction, so this is going to help to separate the vertebrae and relieve pressure on the nerves. We can also carry out transcutaneous electrical nerve stimulation, which involves the use of low voltage electrical currents to treat pain. So this would be in the pre-operative period. In the post-op period, we want to maintain body alignment. If we're going to move this patient, we want to log roll him, and we want to log roll him every 2 hours, and want to put a pillow between the legs. So again, you want to remember that. We'll need to carry out calf exercises. You want to assess your patient for sensation, assess their circulatory status, especially of the lower extremities. We want to monitor elimination. We would also need to assist with ambulation, and we'll need to support the neck, especially after a cervical laminectomy. So if we've done a cervical laminectomy, we want to support the neck. So a cervical laminectomy involves the removal of the lamina, the back portion of the spinal bone in the neck. So this is going to create more room within the spinal canal. Again, during ambulation, we want to maintain a straight back. As part of our client teaching, we want to teach him to exercise daily, but avoid strenuous exercises. They want to maintain correct postures at all times, avoid prolonged sitting, standing, and walking. They want to rest at intervals. They want to use a hard board or a firm mattress when they sleep. We want to teach them to avoid the prone position and also to avoid straining or lifting heavy objects. With spinal bifida or neural tube defects, so this would be a birth defect in which a developing baby's spinal cord or the neural tube fails to develop properly. And it occurs when a developing baby's spinal cord fails to develop or it fails to close properly while in the womb. So so this would be a congenital anomaly of the spinal cord characterized by failure of a developing baby's spinal cord to develop properly or close properly while in the womb. What are risk factors for spinal bifida? Again, maternal folic acid deficiency, very, very important that you know this. And again, previous pregnancy affected by neural tube defect, that would be a risk factor. Our etiology would include advanced maternal age, and again, high levels of alpha fetoprotein if we carry out amniocentesis. With our assessment, you're going to see dimpling at the site, and that will be referred to as your spinal bifida occulta. Occulta means hidden. So again, this would be the mildest type of spinal bifida. You see a small gap in the spine, but there's no opening or sac on the patient's back. So normally the spinal cord, the nerves, usually they are normal. You can also see a tuft of hair or a small dimple or a birthmark in these infants. You can also see a bulging sac-like lesion that is filled with spinal fluid and covered with a thin, atrophic, bluish, ulcerated skin. So that will be our meningocele. So again, you will notice a bulging sac-like lesion is filled with spinal fluid. And if you look at the skin in the area, it will be ulcerated, it will be bluish, it will be thin, and it will be atrophic. So that will be our meningocele. You can also assess the client and see a bulging sac-like lesion filled with spinal fluid and a spinal cord element. So that will be our myelomeningocele. So this is what it should look like. So this would be a sign that your client has spinal bifida. It could be an occulta where we said you would see a tuft of hair or a simple dimple or a small dimple or birthmark. With meningocele, you would see that. So here there's a bulge and is filled with spinal cord, spinal fluid, and also covered with an ulcerated skin. With our myelomeningocele cell, there's some, you can see the spinal cord comes down this way and goes into the bulge and continues, but you don't see that in others. So here the spinal cord continues. So this is just fluid, whereas this is both sac-like lesion with spinal fluid, and again, the spinal cord element. So this would be your myelomeningocele cell. Again, hydrocephalus increases the risk for spinal bifida. Part of our assessment could also reveal paralysis of the lower extremities. We could also see musculoskeletal deformities like club feet or dislocated hips or kyphosis or scoliosis. And then we would also see neurogenic bladder and bowel. The rectum could also be prolapsed. What's our plan for this client? With spinal bifida or occulta, no treatment will be required. With our meningocele or myelomeningocele, surgical repair 24 to 48 hours is recommended. We want to observe for irritation, for CSF leakage, for signs of infection. We want to maintain optimum asepsis. You want to cover the lesion with moist, sterile dressings. We want to position the client on abdomen or semi-prone with sandbags. So again, remember, you want to position the client on abdomen or semi-prone with sandbags. We want to provide optimum skin care, especially to the perineal area. We want to check for abnormal movement of extremity or maybe absent or abnormal reflexes. We want to check for incontinence or fecal impaction. Remember, we said they could have this neurogenic bladder or neurogenic bowel. You want to check for incontinence, fecal impaction. Are there any flaccid paralysis of the lower extremities? We also want to observe for signs of increased intracranial pressure, headaches, changes in levels of consciousness, motor function, vital signs. So again, those are going to give us indications for increased intracranial pressure. In these clients, we want to observe for symptoms of meningeal irritation or meningitis. So you're looking out for sudden high fever, stiffness of the neck, severe headache, nausea or vomiting, changes in levels of consciousness like confusion or trouble concentrating, even seizures. So those will tell us if the client is developing meningeal irritation or meningitis. We also want to provide frequent sources of stimulation that are appropriate for the child's age level. We want to provide post-operative care, especially if he's undergone vertebral fusion or surgical repair. We want to focus post-operative observations on detecting signs of meningitis. We already talked about how we can identify meningitis. You're looking out for signs of shock, signs of increased intracranial pressure. We already talked about that. And also signs of respiratory difficulties. So you're looking out for all of that in the post-operative period. So again, those are complications that can arise. You want to look out for meningitis. You want to look out for shock. You want to look out for increased ICP. You want to look out for respiratory difficulties. With these clients, we want to foster parental bonding. We want to perform family teaching on how to care for their child at home. And we want to discuss family referrals for physical therapy, orthopedic procedures, bladder and bowel management. With hydrocephalus, this would be congenital or acquired condition that is characterized by an increase in the accumulation of cerebrospinal fluid within the ventricular system. And again, it's going to cause subsequent increase in ventricular pressure. So this is what the normal brain should look like. And here you can see that the ventricles are filled with extra fluid. What could cause a child to come down with hydrocephalus may be as a result of neoplasm or aqueductal stenosis. So again, when there's stenosis or obstruction or narrowing in the ventricular system, it could cause hydrocephalus. Clients with spinal bifida are also predisposed to having hydrocephalus, and again, congenital cysts or vascular malformations. And we could have a communicating hydrocephalus. With this, this is due to increased production of CSF or impaired absorption of CSF. So that will be referred to as a communicating hydrocephalus. With non-communicating hydrocephalus, this would be due to obstruction or blockage of CSF circulation between the ventricles and the subarachnoid space. So again, you want to know the difference. So again, with communicating, we said there's increased production or impaired absorption. But with non-communicating, there's an obstruction to CSF flow. In terms of our assessment for our clients with hydrocephalus, we're going to notice a frontal occipital circumference that increases at abnormally fast rates. So again, our frontal occipital circumference is going to increase at abnormally fast rates. We're going to notice split sutures and widened tense fontanelles. So again, so these are our fontanelles. So we're going to notice enlarged tense anterior fontanelle. We're also going to notice widened sutures in this client. So you can see the sutures are widened. Their fontanelles will be tensed. You would also notice the head will be prominent or bossing of the forehead. So there will be a prominent forehead. We would also notice these dilated scalp veins. So the scalp veins are going to be dilated. You will notice this certain sun appearance of the eyes, or what we refer to as sunset eyes. There will be nystagmus. You will notice irritability and vomiting. They will have this unusual somnolence. There will be convulsions, and you would also notice a high-pitched cry. What's our plan for this client with hydrocephalus? So again, we'll mention the disproportionately large size of the head. That's also one giveaway of a client in hydrocephalus. So again, we need to carry out operative management. And one of our operative management would be to put in a ventriculoperitoneal shunt. So again, you can see there's a connection between the ventricles and it's going to end in the peritoneal cavity. So a ventriculoperitoneal shunt is a connection between the ventricles and peritoneal cavity. It's going to help to drain excess cerebrospinal fluid when there's an obstruction in the normal outflow or where there's a decreased absorption of the cerebral spinal fluid. So again, this is one way to treat the hydrocephalus. We can also put a ventricular atrial shunt. So with this, there's going to be a connection between the ventricles and the right atrium. So again, this is going to help to transfer cerebrospinal fluid from the cerebral ventricles into the right atrium of the heart. We can also carry out the ventricular drainage, which is going to help to provide external drainage of the CSF. We would also need to observe our shunt functioning. So you want to observe it and make sure it's functioning as it should. We would also need to observe for increased intracranial pressure and also look out for signs of shunt infection. So look out for irritability, look out for lethargy in your client, look out for a high-pitched cry. Still as part of our plan, in the post-operative period, we'll talk about post-operative positioning. So we want to place the client on the unoperated side in flat position. So again, you don't want to hold the infant with the head elevated. So place him on the unoperated side in a flat position. The shunt will need to be modified as the child grows. We'll need to keep carrying out continual testing for developmental abnormalities or intellectual delay. We'll need to plan our discharge and community referral. Also want to teach the parent about increased risk for allergies if you have a myelomeningocele in this client. So again, we said myelomeningocele that the bones of the spine do not completely form, and it's going to result in an incomplete spinal canal. So again, you will see the spinal cord and the meninges protruding from the child's back. And most children with spinal bifida experience latex allergy. So this is going to make them prone to severe problems such as anaphylaxis. So again, you want to teach the parents that if the if your client who has a hydrocephalus also has a myelomeningeal cell, they need to be alert to the risks of allergies in this client. So again, that will be your myelomeningeal cell. So you can see the spinal tract that goes into that bulge. With Parkinson's disease, this is a disorder of the central nervous system that affects movement, often including tremors. So again, the nerve cell in the brain is going to be damaged, and this is going to cause dopamine levels to drop. We would also say increase acetylcholine levels in this patient. So what we see in our clients with Parkinson's disease, if you look at their face, they are wearing a mask, and that's what's referred to as a mask face or a mask-like expression. You would see tremors, hand tremors, what we refer to as pill rolling motion, almost like they have a pill in their fingers and they are rolling it. So you keep seeing this pill rolling motion or hand tremors. You would also see reduced arm swing when they are walking. So they have this motorized propulsive gait, almost like they are being moved by a motor system. So again, you would notice this reduced arm swing when they walk. There's this back rigidity. You will also notice tremors in their legs, and they will have this shuffling gait, or their steps are short. So you have this short stepped gait. They would have weakness. They will have slurred, monotonous speech. They will have difficulty swallowing. We would also notice salivation and drooling in these patients. They could also be depressed. You could also see dementia in these clients. So what's our plan for these clients? We want to encourage finger exercises. You can have them type or even engage in piano playing. We want to carry out range of motion exercises as appropriate. We want to teach the client ambulation modifications. So you want to refer to physical therapy, like teach them goose stepping walk, or you want to teach them to walk with a wider base, and they want to concentrate on swinging their arms when they are walking. Remember, we said they will have this reduced arm swing. And when they are turning around, you want to teach them to turn around slowly using small steps. As part of our plan, we would also need to promote family understanding of the disease. We want to teach the family that the client's intellect is not impaired. We want to teach them that their sight and hearing are intact. The disease is progressive, but it's slow. But again, you also want to allay the anxiety and tell them that this disease does not lead to paralysis. We will need to refer them for speech therapy, for potential stereostatic surgery. We will need to administer medications like our dopaminergics, like your levodopa, carbidopa. We would also need to give them dopamine agonists like our pramipexole. We'll need to give them anticholinergics like our benztropine. We'll need to give them antivirals like our amantadine. With myasthenia gravis, we're going to see weakness and rapid fatigue of muscles that are under voluntary control. So this condition is caused by a breakdown in communications between the nerves and the muscle. We would also see deficiency of acetylcholine at myoneural junction. So again, with myasthenia gravis, you're going to see weakness and rapid fatigues of muscles under voluntary control. Again, our diagnosis will be based on administration of an anticholinesterase. So if we administer an anticholinesterase to this client and we notice a striking increase in muscular strength 5 to 10 minutes after administration, that would be a positive result. So again, we're going to administer an anticholinesterase like our hydrophonium. So that's a diagnostic test for myasthenia gravis. And if we notice increased muscular strength, that confirms the diagnosis. So again, when we are giving these anticholinesterase, when we want to carry out these diagnostic tests for Myasthenia gravis, you want to monitor their respirations closely. You want to have your atropine available, because atropine is going to help to avoid the side effects of atrophonium, such as a slow heartbeat. So you want to always have your atropine available. So in terms of our assessment, we're going to see muscular weakness in this client that is produced by repeated movements and soon disappears following rest. So when they are moving, or if there's movement, repeated movements, their muscles get weak, and when they rest, they start getting muscular strength. So that's one sign you will see in this client. So we'll see muscular weakness produced by repeated movement, which soon disappears following rest. We'll also notice double vision or diplopia. We'll notice ptosis, which would be that drooping eyelid. So you notice it when the upper eyelid droops over the eye. There would also be impaired speech. They would have dysphagia or difficulty swallowing. You will notice respiratory distress, and there will be periods of remission and exacerbation. As part of our plan, we want to promote family understanding of the disease. We want to teach them that it is neither a CNS or a PNS disease. There's no muscular atrophy or loss of sensation with this disease, and it is not hereditary. As still part of our plan, for this client with myasthenia gravis, we want to administer medications before eating. So you want to give your anticholinesterase. So remember, an enzyme called acetylcholinesterase breaks down acetylcholine, and these anticholinesterase are used to treat myasthenia gravis because they act on acetylcholinesterase to stop the breakdown of acetylcholine. So when they stop the breakdown of acetylcholine, it's going to increase the amount of acetylcholine available, and this is going to help with muscle contraction and muscle activation. So that's why we need to give them acetylcholinesterase, especially before eating. We want to give them corticosteroids. We want to give them immunosuppressants. We would also need to provide good eye care, like artificial eyes, eye patch for the double vision. We want to maintain optimal mobility, provide environment that is restful and free of stress. As part of our client teaching, you want to teach them about the importance of taking medications on time. And again, the dosage depends on their physiological needs and living pattern. They want to wear a medic alert bracelet. We want to avoid factors that may precipitate a myasthenia crisis, such as infections or emotional upsets, or use of streptomycin or neomycin. Remember, these can produce muscular weakness, so you want to tell them to avoid those, and even surgery. So again, they need to avoid factors that may precipitate a myasthenia crisis, like an infection, emotional upset, use of streptomycin or neomycin, and even surgery. They also need to be alert for a myasthenia crisis in case they notice sudden inability to swallow, or sudden inability to speak, or sudden inability to maintain a patent airway. That will be a sign of a myasthenia crisis. With multiple sclerosis, we see demyelination of the white matter throughout the brain and spinal cord. And this condition can actually lead to paraplegia or complete paralysis. So with MS, you're going to see exposed fibers, damaged myelin sheath. That's what we refer to as demyelination. Again, we said it could lead to paraplegia or complete paralysis. In terms of our assessment, some of the early signs you would see would be vision changes, motor sensation changes. Some of the late signs would include cognitive and bowel changes. We would also see muscular incoordination. You would see ataxia. There will be spasticity. We'll see intention tremors. So these are involuntary rhythmic muscle contractions that occur during a voluntary movement. So you're going to see intention tremors. We'll see nystagmus. There will be chewing and swallowing difficulties, impaired speech, incontinence, emotional instability. You would also notice sexual dysfunction. Again, as part of our plan, we want to teach relaxation and coordination exercises. We want to teach progressive resistance exercises like your range of motion exercises. We want to encourage fluid intake, at least up to 2,000 ml per day. We'll need to use warm baths and packs. We'll need to administer medications like our immunosuppressants, your corticosteroids, your antispasmodics, your monoclonal antibodies. We want to teach the client to use a wide-based walk or use a cane or a walker. We want to use weighted bracelets. When you wear bracelets that have weights or cuffs, it's going to help to stabilize the upper extremities because of those intention tremors we talked about. We'll need to carry out bladder and bowel training. We'll need to teach them how to care for a Foley's catheter if they will have to use it. We'll need to teach them or provide self-help devices. We already talked about providing eye patch for the diplopia or the double vision. Again, we said no tetracycline or neomycin or streptomycin because they increase muscle weakness with multiple sclerosis. With cerebral palsy, this is a congenital disorder of movement, a disorder of muscle tone or posture, and it's due to abnormal brain development, often before birth. So again, voluntary muscles are poorly controlled due to brain damage. Some of the predisposing factors will be prematurity, existing prenatal brain abnormalities, trauma, anoxia, or even infection at the time of birth. As part of our assessment, you're going to see ARTHRITIS. So this will be a kind of slow, continuous worm-like movement of the limbs of the trunk, like a worm. So that's what we refer to as ARTHRITIS. That's a slow, written, continuous worm-like movement of the limbs or the trunks. You would also see spasticity. So here there's an abnormal increase in muscle tone or muscle stiffness, and it can interfere with movement or speech. You would see ataxia. So that will be impaired balance or coordination. That's what we refer to as ataxia. There will be atonicity. There will be repetitive, involuntary, slow cross movements. So those are part of what we'll see when we generally assess this client. But in the neonate, what are you going to see? You will notice they cannot hold their head up. They will have this feeble cry, inability to feed, and you'll notice that their bodies ached or limp. With the infants, there will be failure to thrive, so they will fail to develop and grow normally. With the toddler or the preschooler, you will notice intellectual delay, even delayed physical development. As part of our treatment, we want to provide ambulation devices. We want to provide surgical lengthening of the heel cord. This is going to help to promote stability and function. We'll need to give muscle relaxants, tranquilizers, anticonvulsants, baclofen, even our intrathecal pump. As part of our plan for clients with cerebral palsy, we will need to assist with early diagnosis, assist with physical and occupational therapy. So again, this will help to optimize upper body function and even improve coordination of small muscles. Occupational therapy can help children with cerebral palsy master the basic activities of daily living. So you want to carry out stretches, range of motion exercises, strengthening exercises, gait training, aquatic therapy, games and activity, hippotherapy. So these are some physical and occupational therapy we can carry out with these clients. We also want to give referrals to appropriate agencies. We want to provide emotional support to parents and the clients. We want to assist with feeding. So again, when we are feeding these clients because of the muscle weakness, you want to place the food at the back of the mouth, or you place it on either side of the tongue, at least towards the cheek. And then you want to apply slight downward pressure with the spoon when you're feeding these clients. So again, never tilt their head backwards when you are feeding because of that risk of aspiration. They can choke. Again, want to provide high-calorie diet. With muscular dystrophy, this would be a group of genetic diseases that cause progressive weakness and loss of muscle mass. So there's going to be progressive muscular weakness. There's going to be atrophy of voluntary muscles. So again, with etiology, like we said, is a genetic disease. So muscular dystrophy has this genetic etiology or hereditary. And like we said, there's progressive weakness, progressive loss of muscle mass. So again, most times it's progressive, it's terminal. As part of our diagnostic test, we'll need to carry out creatinine phosphokinase test. This is the most specific test for muscular dystrophy. And if the levels are elevated, it's indicative of muscle disease. So we want to carry out CPK, want to carry out electromyogram, want to carry out muscle biopsy. Some of these will be abnormal in the presence of muscular dystrophy. As part of our assessment, there's going to be muscle weakness. You would see lordosis and scoliosis. You would notice waddling gait. There will be joint contractures. We'll see stumbling and falling in these clients. As part of our treatment, we'll need to carry out intensive physical therapy, active and passive stretching and range of motion exercises. We'll need to apply light spinal braces or long leg braces. This is going to help them with ambulation. We would also need to promote safety to avoid those slips and falls we talked about as a result of their gait and movement issues. So you want to use braces or you want to use a wheelchair with this client. We'll need to assist with diagnostic tests. We'll need to educate the client and the parent on the nature of the disease. We want to provide emotional support to the child and the family. We want to discuss balance between activity and rest for this child. We want to prevent contractures and refer to appropriate agencies. With scoliosis, we're going to notice lateral deviation of one or more vertebrae, commonly accompanied by rotary motion. So again, there are types of scoliosis. It could be functional, where you have a flexible deviation that corrects by bending. It could be structural, where it's permanent, and you have a hereditary deviation. As part of our assessment, you're going to see poor posture in this client. If you look at their hips or the scapula, you will notice that both of them are uneven. You will notice kyphosis, lump on the back. So that will be that forward rounding of the back. So you will notice this kyphosis lump on the back. You will notice that their waistline are uneven. So you will notice the waistline is uneven. You would also have direct visualization of the deformity when they bend at the waist at 90 degrees. So part of our plan for this client would be to carry out exercise for the functional type. So you want to teach isometric exercises to strengthen the abdominal muscles. For example, you can have them do sit-ups or pelvic tilt or push-ups with pelvic tilt. We may also need to carry out electrostimulation. We need to carry out electrostimulation. We might need to carry out surgery, maybe with our spinal fusion with Harrington rod insertion, or your dual instrumentation with anterior spinal fusion, or the screw and wire instrumentation. So these are some surgical procedures we can carry out. We can also use a thoracolumbosacral orthotic brace. These types are effective for 30 to 40 degrees curve that are not associated with extreme deformity. So like we said, we can use a thoracolumbral orthotic brace, or we can use a Boston brace, or we can use a Milwaukee brace. As part of our nursing care, we want to carry out skin care in these clients, especially to pressure areas. We want to wear a t-shirt under the brace to minimize skin irritation. We want to teach isometric exercises to strengthen abdominal muscles. We also want to provide activities consistent with limitation, yet allow positive pair relationship to help to promote healthy self-concept. And again, for the brace, they will need to wear it for 23 hours, and it's only going to be removed for 1 hour for personal hygiene. And finally, we're going to look at osteoporosis, which is a bone disease that develops when bone mineral density and bone mass decreases, or it occurs when the structure and strength of the bone changes. And this can also lead to increased risk for fractures or broken bones in these clients. So again, we said it's a degenerative disease that's characterized by generalized loss of bone density and tensile strength, and it can be diagnosed by a bone mineral density T-score. So if you have a score that's less than or equal to 2.5, that indicates osteoporosis. So what are the risk factors for osteoporosis? Age greater than 60 years, small framed and lean body build, Caucasian or Asian race, inadequate intake of calcium or vitamin D, postmenopausal, immobility and sedentary lifestyle, history of smoking, high alcohol intake, prolonged use of steroids. As part of our assessment, you will notice a decreased height in this client. They will have low back pain, especially of the hips and spine. You would also see kyphosis in this client. As part of our plan and implementation, want to give diet high in calcium, protein, and vitamin D. We want to teach about medications. We want to encourage weight bearing on the long bones, such as walking. We want to carry out fall prevention, range of motion exercises, physiotherapy, safety precautions to prevent those pathological fractures. So we want to use a back brace or splint for support. We want to use a hard mattress or bed boards. Again, we'll need to administer medications like our calcitonin. So calcitonin inhibits osteoclasts. So again, this mitigation, these osteoclasts break down the bone. So again, it's going to help to reduce that risk of fracture. When we give our calcitonin, we can give our biphosphonates like our alendronates. So remember, osteoporosis is caused by the cumulative effect of bone resorption in excess of bone formation. So these biphosphonates are going to inhibit bone resorption. We can also give selective receptor modulators like our raloxifene. So again, these ones have estrogen activities in the bone and therefore prevents bone loss. So it's going to help to improve bone mineral density and decrease the risk of vertebral fracture. We can also give estrogen replacement therapy. We've come to the end of the course. I would like to say thank you for listening.